Very good evening and welcome to one and all. I am Monika from Clinic, the designated session assistant for a seamless experience. And Clinic is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Eastern India Zonal Ophthalmological Congress. And the topic of today's session is Voice of East for Kerato Conus.
Good evening, everybody. On behalf of Ajak, I welcome you all to this program, the fourth edition of Voice of East. So we started from West Bengal, then covered Assam, then Orissa, and today is on Bihar. So today the topic is Kerato Conus. We have galaxies of speakers, moderators, panelists, chairman, co-chairman. So with this brief introduction, I request our Secretary Ajak, Dr. Suraj Bhattacharya, to say a few words.
Thank you, CSC, Dr. Sabashachi. Good evening, everybody from the IJOC Secretary. We are here again together for being a part of the webinar Voice of East 2023 Part 4. The Voice of East is a platform for the young generation to come up with academic activities. And with this type of program, the bonding between different IJOC states are being tightened. Through IJOC, our Eastern India is gaining its position and repute in the National Ophthalmic Forum and beyond. We are doing this webinar monthly, covering all the important topics, and will be conducted by the IJOC members of different states in rotation. For this year, the convener of the program is Dr. Devashish Das of Kolkata, and webinar for the month of September will be done by Bihar, the state coordinator being Dr. Ashish Kedia. Today we had a very interesting topic, Kerato Conus, where we had a galaxy of speakers of national and international repute. Dr. Rakhi Shumish from RIO ICMS Patna, Dr. Smuti Rekha Priyodarshini from LBPI Bhubaneswar, Dr. Soham Bosak from Disha Eye Hospital Barakpur, and Dr. Ashish Kedia from Lakshmi Netralaya Patna. Today, panelist group are a bag of young cornea experts, namely Dr. Srikant Shahu from LBPI Bhubaneswar, Dr. Anik Das from Netralayam Kolkata, Dr. Pranita Shahai from Guru Nanak Eye Center, Maulana Azad Medical College, Delhi, Dr. Shamiksha Sabre from Shankar Jyoti Netralaya Patna, and Dr. Nidhi Gatkar from Kashyap Memorial Eye Hospital, Ranchi. Chairperson being Dr. Shamar Bosak from Disha Eye Hospital, Barakpur, Dr. Joy Gopal Agarwal from Patna, Dr. Jahir Ali Siddiqui from Muskan Eye Hospital, Bokaro, Dr. Nilesh Mohan from Patna, Dr. Praveen Subodhi from Behrampur, and Dr. B.M. Agarwal from Shankar Dev Netralaya, Guwahati. All our chairpersons and panelists are also stalwarts in their respective field, covering different IJOC states and beyond. The whole session is being moderated by the two dynamic young personalities, Dr. Rushmika Singla and Dr. Ashish Kedia. With the full support and guidance of our President, Dr. B.N. Gupta, and CSC, Dr. Sabashachi Patnaik, our team is ready with a webinar for the month of September 2023. As an honorary General Secretary, it will be my appeal to all our esteemed speaker, panelists, and the chairs who are yet to join the IJOC forum by taking membership by paying a sum of rupees 2,000, which can be done online or even offline by visiting the website ijoc.in. Lastly, we extend our invitation for the annual conference to be held on 4th and 5th November at Hazaribagh, Jharkhand. We are expecting a great show there. Thank you so much. And please bear for 2 more minutes to have an introduction of the IJOC video. The sound is audible?
Yes, yes. মিটিং চলি আছে মই মিটিঙত আছো
Over to Dr. Sabosati for continuation of program, and next is our president.
So thank you, Dr. Swaraj. Now I request our President, Dr. V.N. Gupta sir, to address us. And also I should welcome our President-elect Dr. Samar Basak to this program and to encourage us. Thank you.
Thank you, Sabosati and Dr. Swaraj. Good evening, everybody. On behalf of entire ISOC family, I welcome all of you to this wonderful scientific program, Voice of East, which has been conducted for last some time, very efficiently and very informative. Today's topic, keratoconus, is very important because in day-to-day practice, we do encounter these patients, and many a times it becomes very difficult to manage this. But of course, we have got an expert panel of experts today who will speak and enlighten us on this very important topic. I welcome all the speakers, the chairpersons, the panelists, discussants, and above all, the master of masters in cornea in our country, Dr. Samar Basak. I am sure today's webinar will enlighten us, and we will be much richer in the knowledge of keratoconus. Thank you very much.
Over to Sabosati.
So thank you, sir. Thank you very much. Now I request Dr. Ashish Keri as moderator of this program to start the program.
Ashish, you unmute yourself.
Thank you so much, sir, for giving this opportunity to be a part of ISOC webinar on keratoconus. And now I request Dr. Rushmika, my colleague, to introduce to start the session on keratoconus and introduce our speakers for the day.
Thank you, Ashish. So keratoconus is one of the most fascinating diseases for any corneal surgeon. The key in managing keratoconus is its earlier diagnosis and management. So we'll be throwing light on all the aspects of keratoconus this evening. So as sir has already introduced chairpersons and co-chairpersons, it's over to you, Ashish, for introducing Dr. Rakhi for the first talk.
So we have first talk by Dr. Rakhi Kushmesh. She is an additional professor at Regional Institute of Ophthalmology, Indira Gandhi Institute of Medical Sciences, Patna. She has done her senior residency from AIIMS, New Delhi. Her area of interest are ocular surface disease and lamellar keratoplasty. She has won several awards, and prominent amongst them is AIR's Cornea Award in 2022 and a most prestigious award of Bihar, that is Dr. D.K. Bose Gold Medal Award in the year 2020. And she has numerous articles, peer-reviewed articles, and she is a very frequent speaker in national and international conferences. I welcome Dr. Rakhi to speak on when to suspect keratoconus and the diagnostic modalities for the keratoconus. Very welcome, Dr. Rakhi.
Thank you, Dr. Ashish. So good evening, everyone. At the outset, I would like to thank organizing committee of ISOC for giving me this opportunity. So in this presentation, I'll be highlighting some clinical clues when to suspect keratoconus and various diagnostic modalities which are available to us. So keratoconus is a bilateral and asymmetrical ocular disease which results in progressive thinning and steepening of the cornea, eventually causes irregular astigmatism and decreased visual acuity. So nowadays we are witnessing increased prevalence of this entity, probably because of more screening done for refractive surgeries, and we have improved diagnostic devices with us.
Number of allergic eye disease cases are on rise, probably because of more urbanization and increase in the pollution. And among ophthalmologists and optometrists, the doctors are more aware of it, this entity. So everybody knows that sequelae of keratoconus has a huge impact on the quality of life, particularly the young individuals, because the disease is bilateral and progressive. And on the top of it, people are not aware of this entity, unlike other ocular diseases. They do consider it as as a refractive error, so they present to us very late. So it's our duty as a eye care professional that we need to detect these cases as early as possible. So to have a very high index of clinical suspicion for this entity, my cutoff values for just to screen these keratoconus patient is low in the OPDs. I always select the patient who are having more than 2 cylindrical power and who have asymmetrical differences between the eyes and who have high spherical equivalent. If the K values are reaching 47 diopter, or if we are not able to give them 20/20 vision, or if the patient is not comfortable with the vision, or if the optometrist sees something related to scissoring reflex, then we want to have one topography done as a baseline or for the documentation, just to rule out the earlier finding. I always want to have the assessment of risk factor in these cases, particularly the eye rubbing cases, because nowadays majority of the people have this complaint because of lot of screen uses, and allergy, atopy, asthma, eczema cases, especially in cases of VKC. If the patient has family history, if the patient already have multiple consultation from the different centers just for the refractive error, then better to have one topography done, or if the patient has contact lens wear history. So overall, our aim to detect the early keratoconus as soon as possible. So we have various imaging modalities with us. Among them, the most common one is the corneal topography. And in corneal topography, it has evolved from the Placido-based topographer to the now OCT-based topographers. But among most common these corneal topographers, the commonly used topographer is the pentacam, which is very sensitive and specific for diagnosing keratoconus as well as subclinical keratoconus. It has one Schimflug camera and it takes multiple scans within a second. So before interpreting this results of this machine, we should look at the quality score and the patient details. I'll just highlighting few red flag signs that we should look at while interpreting this printouts. So it has quad map. First is the axial and tangential curvature map, which gives us the clues about K max or inferior superior asymmetry, skewing of radial axis. In anterior and posterior curvature, we should look at the elevation points. If it is going beyond 15 or 20, then we should have a suspicion. And the pentacam has some cutoff value, unlike other topographers. Then the pachymetry is one of the very important part which should be looked at while interpreting this printouts. This thinnest area, if it is going less than 470, we should have a suspicion. But less than 470 can be present in a simple myopic patient also. So there should be other findings should be taken into account for diagnosing keratoconus or early keratoconus. The prominent part of this machine is enhanced ectasia display given by Bellin and Ambrosio. And here the anterior and posterior elevation points are compared to the standard best fit sphere as well as to the enhanced best fit sphere. And it also gives the difference between a standard and enhanced best fit sphere, which is really good for diagnosing these cases early. And it also gives the thickness profile along with D values, which these parameters are important. So apart from these, it also gives the few surface irregularity indices. These I would say these are important for monitoring the progression of disease, or if you have done some procedure, then these parameters are really important, but not exactly for diagnosis in each and every patient. Second machine, which is commonly used in clinical practice, that is Cirrus. And here, this also has a good sensitivity and specificity for keratoconus and subclinical keratoconus. It has one Scheimpflug camera and one Placido disc-based imaging. So similar to Pentacam, it has same graphs, the corneal thickness, curvature, and anterior-posterior elevation map. But unlike Pentacam, it doesn't have any true cutoff values. And manufacturer have given few important keratoconus indices values. Other than that, you don't get any anterior elevation or posterior elevation data in this machine. So similar to Pentacam, this also we need to have a quality check before interpreting it, and we get some summary indices. The important thing in this machine is it gives shape indices in form of RMSA, that is root mean square per area, and it shows the cornea irregularity. If the values comes very low, then it means that cornea is more regular and it is towards the normal. And if the values are very high, that means cornea is even very irregular. So it also gives the enhanced ectasia display, but not with the name of Bellin embryo. And we can also see the thickness profile in in this machine. So overall, this machine actually gives a keratoconus screening. It's done by various parameters, and then this machine takes all the parameters. These values are really difficult to remember in this machine, but it takes all the values into account. And by using AI system, it gives the classification of the keratoconus or categorized into different category, so that it can be categorized into keratoconus, suspect, or the completely abnormal or borderline cases. We can also follow up these cases on Pentacam and the Cirrus topographer. The lacuna in Scheimpflug based topographer is that in cases where the scarring is present, if there is any corneal haze, edema, then the values are not reliable. This is a limitation of Scheimpflug based keratotopographers. So here comes the role of anterior segment OCT based topographer. Those are the Kesha and Anterion. And here the values are the reading of printouts. The interpretation is very similar to the Pentacam and Cirrus, but there are things which makes it spatial. That is the picture, the topography. You can get topography even in presence of the scarring or the significant haze. That is important for us. Another very important tool in the keratoconus diagnosis is the biomechanical property of cornea. It can be measured with the machine ocular response analyzer in form of corneal hysteresis or resistance factor, but it has poor sensitivity and specificity. We cannot use this machine in isolation for the diagnosis of keratoconus. Another thing which is nowadays gaining a lot of popularity is Corvus ST. It gives two important parameters. One is the Corvus Biochemical Index, CBI, and second one is the TBI. Its data is actually integrated with the Pentacam, both from the Oculus, and then its sensitivity and specificity actually become very good, 100%, nearly 100% with the TBI. So it's a good machine to know whether this patient is going to develop keratoconus or if there is anything in process. So this machine, even this machine cannot be used in isolation for the diagnosis, but yes, along with Pentacam, it is very useful. Last few years, people are more interested in measuring epithelial thickness because it has a very important role in discriminating the true progression or pseudo progression. So we know that epithelium actually it changes its thickness, and it rebuilds itself in response to the stromal changes. So as the stroma gets steepened, epithelium in that area gets thinned out. So if we measure this epithelial thickness in early stages, then we can know that this patient may have keratoconus, frank keratoconus in future. So this is one of the tool which can be used very effectively for diagnosing early keratoconus. And it gives, in early stages, it gives a classical epithelial donut appearance, where the central part of epithelium is thinned out and peripheral part is thickened. The confocal microscopy, even this machine cannot be used in isolation. It gives the detail of microstructure of the cornea. So if you are treating any patients with the drugs or some procedure, you can monitor these patients with these data, or even these data can be used for the research purposes. So to summarize, early identification of keratoconus is still a diagnostic challenge, even after so many machines. So evaluation of risk factor, good clinical workup, and with the good quality imaging or early imaging actually can help in timely detection and intervention of the keratoconus. Thank you so much.
Thank you so much, Dr. Rakhi. It was a great talk. I would like to our panelist, eminent panelist, Dr. Shrikant.
Yeah. Hello. It was
Yes,
good.
please go ahead, sir.
What we rarely have not worked on is the epithelial component of keratoconus. Like now, there is a good amount of talk about the best membrane transplant as an option for keratoconus. So there is some interaction between the collagens of the epithelium basement membrane and the stroma, which leads to keratoconus. We are yet to understand that. As you said, rightly suggested, if we look at that very more carefully, more clearly, probably in the next few years, we'll be able to understand at what stage we can arrest this disease so that we don't have to really progression apart from collagen cross-linking, where we cross-link the stroma. If we can arrest the disease at the epithelial, when we know, okay, this guy is going to develop a keratoconus and we have some kind of modality for that, that would be awesome. So nice presentation. The focus changes from the real pathology of stroma to the pre-nomination factor of epithelium and basement membrane, the transaction between epithelial basement membrane. So that is one thing which is the way forward for keratoconus.
One more general question, which everyone in their mind is, like, she has introduced many machines. Which is the best machine? Which is the best topographer or tomographer? And there's always a debate, and I think there is no answer, but would like to listen from Dr. Pranita. What do you think for a general practitioners, or for a general practitioners, which is the best, and for a cornea specialist who's actively doing corneal surgeries or refractive surgery, which machine would you suggest and why?
Yes, Dr. Giri, I think this is one of the most interesting questions. And as of we all know that the gold standard for any topography or a tomography system is the Pentacam, that I think universally everybody is using. But what is the hot topic recently is with the entry of Anterion in the market. A lot of people are trying to opt for Anterion as it is giving us a comprehensive testing for both IOL power calculation and the topography. So basically, there are few studies which have compared Anterion and Pentacam, and although the Pentacam is found to be a little more sensitive compared to the Anterion, but clinically, the differences are not really very significant. For a general practitioner who's going on for refractive, for the purpose, who's doing topography for the purpose of refractive screening, I think even the Anterion gives equally good result as for Pentacam. But if you really ask me from the point of view of a cornea specialist, I think Pentacam is the gold standard test for, particularly managing keratoconus patients.
I think that's the universal answer. We always hear and always believe that Pentacam is the best.
Sure.
Dr. Raki, which machine do you have? We have it at IGMS. Is it Pentacam or it's a Cirrus?
No, it's a series. So initially we were habitual of reading Pentacam just to, it's really easy in comparison to Cirrus. But now I feel that Cirrus is not that bad. It's a really a good machine and it gives extra findings, abrasions and there are many other things which you cannot get from the Pentacam. But definitely the reading part for particular keratoconus part, I would still say that Pentacam is easier to handle than the Cirrus. But yes, follow-up should be in the same machine. Then you will get the same findings, same data, same sensitivity, everything.
And I agree with Dr. Raki that Cirrus does give us a lot of additional information. Recently, as I joined GNEC, they have a Cirrus machine, and throughout my residency time and every time I had the Pentacam. So it's really difficult to switch from Pentacam to Cirrus because the value, the presentation, everything looks very different, and the cutoff values are not very as clearly defined as is for Pentacam, as ma'am told in the talk. And also the values that we see in the numerical display always does not corroborate very well with what we see in the maps. For example, in a Pentacam, if you go and look at the Kmax in the map and in the value on the numerical display, it always correlates. Somehow I did not find that in the Cirrus scan. Maybe I'm new to it, so I was not able to see that correlation somehow.
Ashish, I'll just like to it's not the machine which detects, it's how we interpret the values of the machine which is more important. So some of us have Cirrus, some of the Pentacam. How we interpret that makes a difference. We cannot have all the instruments the best possible. Which is best, even I will say Pentacam, Raki would say PA. But how that's a human which interprets the machine, and that depends.
Very true, sir. Totally agree.
Machines are good, but humans are, how do you interpret the machines?
Humans are best.
I think I believe that the machines which we are trained with from the very beginning is the one which we are very comfortable with. And that is what I feel. But again, we should be open to all the newer machines which are coming into the market. Like I've been trained with Pentacam. So Cirrus to me looks very foreign. I'm not able to interpret much except the K release and the thickness. Somehow I'll diagnose keratoconus in that, but will not be very confident. That is what
probably the difference. Suppose it's like Humphrey and octopus. Humphrey is so prevalent. Everyone talks about the Humphrey. No one talks about the octopus. Both are actually good machines for the field analysis. It's the same thing, I think, for the Pentacam, because Pentacam is more prevalent. Everyone has a Pentacam, and Cirrus is not that prevalent. Most of the studies are on the Pentacam. That is the reason. Otherwise, I don't see much of difference between two machines.
Very true, sir.
So before we head on to the next talk, just one last basic question. We get many times cross-referrals if the cylinders are high, like Dr. Raki mentioned, if it is more than 2. But many times I've seen that if the cylinders, the axis is at 180 and 90 degrees and the cornea is still steeper and there's high cylinder, still people refer to see whether, to rule out whether it's a keratoconus or not. What do you think, it is justifiable to do Pentacam in all these cases where the cylinder is more than 2 and the axis is 90 and 180 degree? What is the opinion of the panelist in that? Anyone can take, please.
Ashish, I had a patient last week whose vision was good. 2020. I'm repeating 2020 parts. The estimate on year returns was -2 or 3. On Pentacam, the vision was like on Pentacam, it was diagnosed keratoconus, but the patient had 20/20 vision. But the only complaint was, I see a shadowy vision. So there, if you see the 20/20 vision, you find this okay. But even with glasses, they do not recover. So those are the cases when the patient is not happy with 20/20 vision. with the best carotid cylinder area, probably we need to do a topography.
And also, Dr. Ashish, in the current era where the medical legal cases are going with escalating at such a high rate, everybody wants to be safe. Nobody, wants to take any chances, especially if you are working in a private setup. I think it is always safe that if the cylinder is more than 2 and your keratometry also is borderline, it's better to go for a topography rather than wait.
I differ, Ashish, I differ in 1 year. Whether a private setup,
Or in a government setup.
space is the same, medical is the same. All the same.
Additional risk in the private setup.
All the same.
Just to add to this, I mean, it probably gives confidence to the referring the doctor, the parents also. Once you have a topography and tell them it's normal also, sometimes that also adds to the confidence. When there's no harm, it's a non-contact test, there's nothing harm in getting it done. So like whatever referrals they get for like 3-4 cylinders, I get it done and tell them it's normal. You go back to your referring doctor.
And the threshold can be lower even in cases of VKC and allergic conjunctivitis. Even 1.5 astigmatism coming up in kids with VKC. I think I always go for a topography in these cases.
Yes, it also depends on the age of patient. If the patient is young and coming with this much of astigmatic power, then better to get one topography done just to baseline or to compare in future.
Yes. Dr. Rushmika, would you like to introduce the next speaker?
Yeah, sure. So after a wonderful talk by Dr. Rakhi, let's move on to our next speaker. Before that, adding on, Dr. Nilesh Mohan sir has also joined the meeting. Due to some reasons, he was late. So Dr. Smruti Rekha Priyadarshini has completed her cornea and anterior segment fellowship from Arvind Eye Hospital, Madurai. Dr. Smruti has special interests in refractive surgery, lamellar corneal procedures, and ocular surface disorders like Stevens-Johnson syndrome and chemical burns, etc. She has many publications in peer-reviewed indexed journals. Presently, Dr. Smruti is working as cornea consultant at L.V. Prasad Eye Institute, Bhubaneswar. So, welcome, Dr. Smruti. Dr. Smruti will be talking on recent advances in collagen cross-linking technique.
Thank you, everyone, for inviting me and giving me an opportunity to present this. And is my slide visible? Are you able to see the slide? Okay. Yeah, thank you. So I'll be presenting on the following outlines: introduction, mechanism, indications, modifications, and outcome. So we all know that keratoconus is a chronic progressive disorder, which is characterized by progressive thinning, ectasia, which causes irregular astigmatism and visual impairment. And it starts in the pubertal age groups and progresses till the mid-30s. Progression in various studies have found to be somewhere around 25 to 30% of cases. Now, collagen cross-linking, which was introduced by Wolsak in 2003, is a very minimally invasive procedure and is a safe treatment for progressive keratoconus. The aim of this is to slow and stop the progression so that the need for keratoplasty can be avoided. So it has, after the introduction and performance of this procedure, it has significantly altered the management of keratoconus in many aspects. So briefly about how the cross-linking, the mechanism behind cross-linking. So it to strengthen the stroma by increasing the number of covalent bonds between the collagen molecules. So basically, we have the riboflavin, which acts as a photosensitizer, and it gets activated by the ultraviolet A light, which creates free radicals and induces cross-links between the collagen fibrils. Now, this results in increasing the biomechanical rigidity and increases the collagen fiber diameter. It also increases the resistance to pepsin digestion, and finally, it causes biomechanical stability. So what we can see is in these two photos, before cross-linking and after cross-linking, we can see that the number of covalent bonds has increased. And if we can see the corneas, which are in the right-hand side, we can see that the strength or the biomechanical rigidity is much more in the upper cornea than in the lower porcine cornea. So where is it used? Mostly it is used in cases of progressive keratoconus, in cases of pellucid marginal degeneration, in post-LASIK or post-refractive surgery ectasias, sometimes in microbial keratitis and bullous keratopathy, although we do not use it frequently, but it has been reported in literature.
Excuse me, Smriti,
Yes.
your slides are visible, but you are not visible.
Yes, sir. Sir, my video is not working, so I really apologize.
Okay, thank you.
So preoperatively, before ordering a cross-linking or before asking for a cross-linking patients, we should a corneal topography. We have just listened to the wonderful topic. We know how to interpret and how to look for the progression. Progression should be documented on serial visits, at least 3 months or 6 months. We have to take serial topography images and look for progression. However, in certain cases, like a young child who is come with a active VKC, there we can think of doing it in the first go. Otherwise, it is always when we see a progression, we advise it. The other indication is whenever a patient is coming to us and already is in the advanced stage and it's a borderline pachymetry, waiting for more than 6 months would actually bring down the K reading, bring down the pachymetry. In those cases also, we can advise cross-linking in the first go. Then a pachymetry is very important, a preoperative pachymetry, so that we know whether we can perform this procedure or not. And specular is optional because there are certain studies which have shown that it can also affect the Descemet's membrane and the endothelial cells. So specular is an optional, but it can also be done. So the standard procedure or the approved cross-linking procedure is involving is first the removal of the central 7 to 8 millimeter of the corneal epithelium by using either a 15 number blade or a hockey stick blade. Then addition of riboflavin, which facilitates the penetration of the compound to the stroma, finally exposing it to achieve a total fluence of 5.4 joules per centimeter square to allow the cross-link to form. The various challenges are the epithelial removal causes significant pain. First 3 days at least till the epithelium gets it re-epithelializes. There is significant pain and discomfort in the initial 3 to 4 days of surgery. There is always a risk of infection, prolonged surgical time, but again this has been addressed by the accelerated procedures which have come in market, and the thin pachymetry. A minimum of 400 micron is recommended, but if somebody has a pachymetry between 350 to 400 micron, now they are often not suitable. So address these issues, there have been various modifications like the following procedures: like transepithelial or contact lens induced, accelerated, antiphoretic methods, and with the refractive surgeon extra procedure. So riboflavin, so coming to these riboflavin, whenever we have riboflavin has a very high molecular weight, so this hydrophilic molecule does not penetrate the intact epithelium. So the following agents like BAC or ethylene diamine triacetic acid or tetracaine, it contains it whenever it is applied before the riboflavin, it loosens the epithelium and it allows the penetration of the riboflavin. So the depth of demarcation line is 200 micron, and when we compare the standard protocol versus the transepithelial method, the biomechanical rigidity, it increases to 64% as compared to 320%, which is in the Dresden or the standard protocol. So whenever we have this thin corneas, we can use other things like instead of an isoosmolar, hypoosmolar riboflavin can be used. The transepithelial method, iontophoresis, lenticular assisted method, and the contact lens or the customized epithelial debridement procedure. So hypoosmolar, the conventional protocol, the riboflavin used is 0.1% in 20% dextran. In an hypoosmolar, riboflavin is used without dextran and it is less. The osmolarity, if you can see, it is 310 as compared to 402. So this leads to the increase in the pachymetry up to 110 micron, and there is no endothelial cell loss. So the cornea undergoes a temporary swelling and the cross-linking can be performed in this procedure. This is I think most of us will agree that we use this method whenever we have a Pachy of 350 to 400 micron. The other techniques are the epithelium off technique and the UV barrier, the soft contact lenses. First, the contact lens is soaked in 10.1% riboflavin for 30 minutes, and it has been seen that it causes up to 70% stiffening as compared to the standard resin. So it is not as equivalent to Dresden protocol, but yes, we have a technique which can address to thinner corneas also. So the transepithelial, the transepithelial method, there is a water-soluble low molecular weight riboflavin. The penetration is increased by the use of a low-intensity current. Now, the iontophoresis, it provides a greater and deeper riboflavin saturation than the Epi-on technique and shortens the time for requirement. Now, sometimes some authors have also mentioned the use of the smile lenticule, where the lenticule is placed over the apex of the cone after the debridement, and after that, based on the pachymetry, the standard treatment is followed. Now, sometimes we know that the apex, the thinnest part where the apex of the cone is, sometimes we can just spare or we can avoid debridement of the epithelium over that apex of the cone, and that actually protects the cone, and the surrounding area can be debrided, so that causes penetration of the riboflavin, and the cross-linking can be done following it. So accelerated is when the same energy is delivered as the conventional, but in a shorter period of time. The advantage is that it reduces the treatment time. In the conventional protocol, if we think of 3 milliwatt, then it takes up to 30 minutes. The initial riboflavin, the thing takes up to the ultraviolet radiation is up to 30 minutes. But if we try to increase the milliwatt, like up to 18 or 9 or 30, then we can deliver the same amount of energy in a much shorter time. So this significantly decreases the operation time. Now, the cumulative dose have to be remembered to be 5.4, and it can be titrated depending on what machine you have. Sometimes the management of keratoconus requires a holistic approach. The purpose is not only to halt the keratosis or the progression. Sometimes we have to also think of measures to reduce the irregular astigmatism and correct the residual refractive error. So finally, we all aim, the aim should be to improve the functional vision. So this is the main thing, and that can be achieved by various methods like conductive keratoplasty, or combining it with PRK, combining it with intracorneal ring segments, sometimes phakic IOL or transepithelial phototherapeutic keratectomy can be combined. So for those patients who are patients who have a documented vision, they have an unsatisfactory visual function, and sometimes they are tolerant to contact lenses or spectacles. So these are the candidates where we can think of combining the latest techniques like LASIK extra, PRK extra, SMILE extra. So cross-linking is it's a prophylactic procedure. So when we are doing LASIK in such patients, and patient has a borderline, so we can think of doing a cross-linking on top of it, so that it can decrease the risk of a post-refractive surgery ectasia. So those patients are those who have a high refractive error and a borderline pachymetry. So these are various protocols which are available. When we have the Athens protocol is like we are doing topo-guided PRK up to 80 micron max with a high fluence cross-linking. That is the Athens protocol. Sometimes we do a transepithelial PTK, then a cross-linking, which is a Cretan protocol. And if we are doing a PRK also, then it is a Cretan plus protocol. And as I mentioned, we can also do cross-linking along with intracorneal ring segments or with a transepithelial topo-guided PRK or with a toric phakic IOL. So these are the various combinations that the surgeon should be comfortable, and based on the requirement and the eligibility of the patient, we can select one of these procedures to go ahead with it. So the outcome is, or the corneal response should be in terms of it should be an improvement in the corneal curvature, that is the stabilization, and then it should improve the uncorrected and the best corrected visual acuity. But whenever we are advising cross-linking in such patients, we should also make them aware that the contact lenses are also going to benefit them. So it is not always the cross-linking that will help, but it will stabilize it, and further they will need contact lens to get the maximum outcome. So these are the various studies. This is a 3-year study where they have seen that there is an improvement in the Kmax uncorrected, best corrected after cross-linking. This was one of the initial studies where after the introduction of the cross-linking. This was a 10-year study where they have seen that cross-linking has a very good safety profile, and this reduces the need for a corneal transplantation. However, it does not go without any complication. Whenever we are putting a bandage contact lens, there is always a risk of having a microbial keratitis. Most often, it is a sterile infiltrate. As we can see here, some of the photos are like they are on the edges of the epithelial debridement, exactly at a 8 millimeter zone where the epithelium has been debrided. So we can see that there are infiltrates, very well-defined infiltrates. Most of them are sterile infiltrate, but then since it's the post-operative thing, it should also be kept in mind. Then corneal haziness, corneal edema, if the penetration is very deep, and it can sometimes cause a decrease in the endothelial cell and cause corneal edema, which is seen post-operatively. Corneal haze also is a common feature which is seen, which slowly regresses with time. So to conclude, corneal cross-linking has been shown to be effective to halt progression, especially in eyes with keratoconus and other ectasias. It is easy to perform and has a very good safety profile. There are various modifications, as I've mentioned. It is the quality of vision that improves when it is combined with a refractive surgery. And finally, it also reduces the need of corneal transplantation. But having said so, I will also mention that for keratoconus, one of the other treatment modalities that is also gaining popularity apart from the RGP lens is the scleral contact lenses. So I think with that, I would like to end my presentation, and I would be happy to take any questions.
Thank you so much, Dr. Smruti, for such an elaborated and nice presentation. So nice to see LVP logo after a long time on the screen. So I would like to welcome questions and discussion through panelists, chairpersons, and would like to ask Dr. Anil Das. Sir, are you there, sir? He has special interest in collagen cross-linking, working at Netralayam Eye Hospital, Calcutta.
Yes, good evening, everyone. It was a very good presentation by Dr. Smruti. She has covered everything in her presentations. So I would like to add 2 points. One is specular. What she has already mentioned, specular is very important, especially in thin corneas, preoperatively, because when we do the CXL, collagen cross-linking process, if patient has a thin cornea, sometimes it can affect the endothelial cell layers also. In thin cornea, normally we use hypoosmolar agents. So it has the, after using the hyperosmolar agents, the corneal thickness, how much thickness cornea has gained, we should check intraoperatively also. So in my cases, especially in thin cornea, where I am using hyperosmolar agents, after soaking, I do, sterile pachymetry in my cases, whether it has reached 400 micron or not. If it is not reached 400 micron, I add some sterile water. I keep it for at least 10 minutes, and then again I check it. If it is reached the 400 micron, then only I proceed for collagen cross-linking. I think it is the safe to proceed.
Yes, sir. I totally agree with you. We also follow the same thing. We do not usually start the radiation until and unless we see a pachymetry of 400 micron. So that is one thing. But I would also that in a few studies recently it has come up that sometimes the exposure with a speculum also dehydrates the cornea. So in those cases, whenever I feel that the cornea is going to go below the baseline and I'm going to end up in such a situation, I put the riboflavin and ask the patient to close the eye so that that riboflavin stays in place, and the cornea, the evaporation also, the desiccation does not happen. And it is always safe to talk to the patients that those who have a borderline pachy, that we may have to abort the procedure in between if the pachy does not go till 400 micron. So it is always good to document and write down so that if at all we have to abort, then they don't feel bad. They know that we have tried our best and it still hasn't worked.
Dr. Smriti, I just wanted to add one thing. I mean, do you do contact lens assisted C3Rs also in these patients? Like rather than abort the procedure, would you not plan for a contact lens or a lenticule assisted C3R in these patients?
I have not tried, but I think we can plan in such cases. I think in my last 7 years of experience, there have been 2 instances where I have aborted the process, but maybe the contact lens thing, but it has to be kept in mind and it needs 30 minutes of soaking in riboflavin.
Yeah.
So that has to be taken into mind.
I think it's best to plan this patient with these backups. Like if you have a UV barrier-free contact lens, you keep them pre-soaked. And just in case if you're not able to achieve a more than 400 pachy, rather than aborting, we can shift to a contact lens assisted C3R in these cases.
Pranita, I just want to extend what you said. Can we say goodbye to ifs and buts?
Yes, sir. So personally, I go for contactless assisted C3Rs in this patient.
So there are 2 questions now, which needs to arise between all of us. One, can we develop, apart from the hypoosmolar riboflavin, a molecule which ascertains us, even if it is a thin cornea, we put the molecule, the cornea will be so dark, thick, that it will not damage the endothelium. Question 1. Question 2. Contact lenses, we know, you and me know, are not predictable for the outcome. So that is why most of us are hesitant to use a contact lens based treatment, because we know that it doesn't penetrate it. So the question of that is what the beauty of biology is. Can we develop a contact lens where it penetrates the UV lenses penetrates without affecting thickness or without affecting the effectivity? Because right now, it is proved that with contact lens, the efficacy is not that great. Because the contact lenses are made for different purposes. They are not made for the collagen cross-linking. We use it as substitute. So can one of us think of it, find it a contact lens which transmits this laser lights, but does not affect the effect? 1. 2. Is there any other way where we can predictably say, and this is the take-home message from this webinar, that can we develop a molecule where we can predict, okay, your thickness is 320. With this molecule, it will become the 420 and not affect the endothelium. So right now we are doing good. Can we do better in the question? 2 options. 1, develop a molecule which thickens the stroma. 2, develop contact lens which does not affect the effectivity of the collagen cross-linking.
Thank you, sir, for the insights. With this, I would like to ask Shrikant, sir.
Can I chip in here?
excuse me, can I chip in here? So I just want to.
Yeah, sure.
Yeah, I'm Dr. Praveen. Smriti, it was a nice presentation.
Yeah.
I want your experience on whether there is any option for partial fluence cross-linking. Do you have any experience of partial fluence cross-linking in refractive surgeries? Or you feel that there is no thing like that partial fluence, it's always the total fluence?
No, you can also individualize it depending on the need, but I do not have an experience. We have always used it, but it can be individualized based on the need. Individual cross-linking, you can lower the UV dose and do it. And that's for the theory part. I have not experienced yet.
So any other panelist has any experience regarding this partial fluence in refractive surgeries?
Yeah. So basically, sir, we have done LASIK extras, PRK extras, and smile extras, at least in borderline corneas where the topography is borderline. They're not clear-cut frank keratoconus cases that I'm talking about, but those with borderline or suspicious topography. In them, yes, we do cross-linking in addition to refractive procedures, but not in frank keratoconus patients. But in these cases, corneal haze post-refractive surgery is always a concern that needs to be
Exactly. I have the similar experience in the growing of the epithelium also little bit slows down after doing cross-linking.
Compared to normal PRK, if you go PRK extra, the healing takes another 3-4 extra days. And we have had few patients who had loss of BCVA by a couple of at least 2 lines, in some cases who underwent PRK extra. So that is one concern that comes up with this combination.
So
can I come in, Dr. B.M. Agarwal?
Yes, sure, sir, please.
No, yeah. So, what is your experience with with BSS along with your hyposmolar? If we add, sometimes it does not. Then I think if we add both, so sometimes we can reach to the 400 also. In my cases, I'm using sometimes not then mixture of this 3 to 4 minutes for around your BSS, and then along with that hyposmolar. So I'm getting a good result with that. So what about others? I don't know about this. So anyone have experience on this?
Yes, sir. Actually, what I do in my practice, I use hyperosmolar agent. If it doesn't reach 400, then I put BSS for 3 to 5 minutes. And then after 5 minutes later, I checked the pachymetry. So in my case, I have seen it has most of the time it crossed 400.
Yeah. Another question is, yes. Another question is, instead of removing alcoholic removal of epithelium, if you do the PTK and then the CXL, I think the haze and other parts, it will be better than, I think. If you have the machine to do the PTK, instead of removing the epithelium, and just do the PTK and then do, I think the healing part also becomes better, and the pain and other things also become lesser comparing in your even the infection part. So I want to ask the panelists about regarding this, what is their experience?
Any views, Dr. Nidhi?
I have one doubt regarding this question. Doing a PTK instead of alcohol removal, because PTK you are again using the lasers, and laser itself may induce some amount of inflammation. So that's one of my concern, using a PTK instead of an alcohol related epithelial removal. But if the inflammation happens, then again there is because as we know that the stromal lysis which is happening in keratoconus has some inflammatory pathology, and if you are again inducing some amount of inflammation, there may happen to be a stromal lysis, which I feel personally I don't have that experience. That's why I always prefer performing alcohol related removal, but I have tried once, but I'm not that happy.
I agree with Dr. Praveen, and I think this will massively increase the cost of the procedure for the patient as well.
Yeah, cost is one factor, true, but I think inflammatory part I can't, because I'm doing regularly, but I didn't have that much problem. That's why Actually, I don't know.
No,
what are
cost
that.
aside, I mean, that would be the principle of the
Yeah.
Cretan
Yeah.
and the Cretan protocol plus having a PTK-based epithelial
Correct.
removal. It actually improves the some of the superficial irregularities. You have
Correct.
some improvement of the visual quality. I have done few over the last 3 years, maybe around 20, 25 of them. And
Yes.
I prefer giving them steroids for a little longer period of time, maybe 3 to 4
True.
months in
True.
these patients.
Yes. Yes. True. That part is.
We are trying to improve the aberrations or trying to take care of the refractive error or astigmatism. That is where the laser comes in. And if it's just about removing the epithelium, I think manual removal of epithelium is something which is very easy in keratoconus patients. I always prefer to do that rather than going for alcohol-assisted removal. I think the epithelium recovery is a little slower when I remove the epithelium with the alcohol. That is what I had faced, and I switched completely to manual epithelial removal. Anybody has an experience like that?
All right.
Yes, I have similar experience.
Before we move on to the next, sorry, Dr. Rakhi, you want to say anything?
I was telling that I have similar experience of removing the epithelium with mechanical debridement, just debridement, and with alcohol assisted, as the Dr. Pandita said, that the haze and healing haze is less after mechanical debridement and healing is faster. So I always feel that it should be removed mechanically rather using some alcohol or other things.
Can I ask a question to Dr. Smriti, ma'am? Hello.
Yeah, Dr. Selection there.
Ma'am, in pediatric keratoconus, what is the lower age limit to do a C3R?
Lower age, I have done even in eight years of age. This was way back when I was a fellow, and it was a patient of keratoconus with active VKC. So I had no other choice but to do it. But at that time, I did under general anesthesia. But right now, I think if we little convince them and with the accelerated protocol, we can do it quite fast.
I think I've even done it at 6 years of age. I think age is not something that is of consideration. We just have to document it as KC. And for pediatric keratoconus, I think we don't even wait and watch for progression. If it is keratoconus, you do a C3R. Age is not something to be considered there.
Okay, ma'am. Okay. So with this note, I feel Dr. Ashish,
before
we'll move with the. Yes, anyone?
Yeah, I was saying there was
session.
Some people are using a hyper oxygenated riboflavin or oxygen mask for the epithelium on CXL. What is the experience of the members here? Is it a good like epithelium off, or is it or not?
I haven't personally used it, but I know there was a thesis going on with Dr. Rajesh Sinha at RP Center, and the results are yet to come out. That's the only thing that I've heard. I don't have no experience on it.
So after this wonderful discussion, let's move on to the next talk. Dr. Ashish, over to you.
Yeah. So next talk will be by introducing Dr. Soham, who has done his MBBS from Kasturba Medical College, Manipal, and then followed by Masters from Arvind Eye Hospital, Madurai. He is a fellow of Royal College of Ophthalmology, Glasgow, and he has also done short-term ICO observership from Mass Eye Infirmary, Boston. And he has several papers, and he's a very frequent speaker at international and national conferences, and a winner of many awards. And he's also a reviewer of IGO and the prestigious Cornea Journal. I welcome Dr. Soham, and he'll be talking on special contact lenses in keratoconus. Over to you, Soham.
Thank you, Dr. Ashish, for the kind introduction, and thank you, ISOP, for giving me this opportunity. Let me just get this. So is the slide visible?
Yes, yes.
Okay. So I'll be talking about specialized contact lenses for keratoconus. I have no financial interest in this talk. So specialty lenses, as Dr. Priyadarshini was just saying, so that's what will arguably get you the best vision in keratoconus. And to have a small nitpick, not all specialty lenses are quote unquote contact lenses. So I'll be talking briefly about when to use these lenses, what are the types of lenses, very briefly about fitting and some practical tips about counseling and how to choose your patients. So prerequisites, ideally you would want to fit these specialty lenses in non-progressive keratoconus. Maybe they're old enough, or maybe you have done a cross-linking. If progressive, the patient should be made aware that the lenses might change with time. Very important to control ocular allergy because they can aggravate the papillae. The child or the parents should understand the importance of hygiene. Then it's important to have Scheinflug and keratometry readings before fitting. Ideally, you should be able to fit it yourself or have a trained optometrist to do the fitting, because this is something which requires specialized training. And there are actually a lot of these workshops going on by LV Prasad and AIOS and throughout the year. So definitely make it a point to attend one of these. And they should be able to follow the instructions of the entire contact lens maintenance process. So lenses can be given after collagen cross-linking. It can be given after DALC surgery, ring segments, or even the newer keratoconus surgeries that the previous speakers were talking about. So it should be, before fitting these lenses, we should be aware that fitting these lenses is a very long and a patient-taking process. So patients should be made aware that sometimes even as long as 4 to 6 hours per session is required for the fitting contact lenses. And sometimes they need to come multiple trial sessions, because sometimes in one session, it's very difficult to fit them in the contact lenses. The aims of contact lens fitting would be to give them the best possible vision with good fitting parameters and good patient comfort. This should be your endpoint of any of the specialty lens fittings. The types of lenses would be the good old soft contact lenses, the rigid gas permeable lenses, including the specialized rose-K lens, the scleral lens family. So this is basically the corneoscleral lens, miniscleral lens, scleral lenses, and then special mention about hybrid lenses and piggyback lenses. So soft and soft torics, they are very comfortable, but of limited use in keratoconus, can be used in early keratoconus, offers some improvement of visual clarity than your spectacle vision, or maybe after DALC when the cornea is regular. And the problem here is the high cylinder lenses are actually very limited in supply. And if there is anisometropia, sometimes you have done DALC in one eye, so the power is very less. So then it would be important to tackle this anisometropia. Soft contact lenses can be given. And in softer contact lenses, it is better to go for something with a low water content to neutralize the irregular astigmatism, and something with a larger diameter. Now, the rigid gas permeable contact lenses, this is what is most widely used. This gives probably the best visual outcome, but the comfort level is moderate, and it cannot be fitted in extremely steep cones. It basically converts the irregular cornea to a regular corneal surface. And there is some importance of the intervening tear lens. So that's basically the very thin layer of tear film that is trapped between the cornea and the posterior surface of the contact lens. So there is a very good outcome even with keratoconus with apical scars and also with post-eye drops patients also. However, this is something to be keep in mind, that sometimes this central touch can aggravate the apical scar. So that is something which you would want to avoid. So the very simply put, the fitting principles, you would want to look at the static and dynamic fit. So with each blink, the lens should move a little bit, but not too much. And it should ultimately come to rest towards the center of the cornea. So use fluorescein stain to look at how the fitting looks like. And now the yellow filter is also recommended. So the type of fitting would be apical clearing, which is the first picture here. So you can see pooling of fluorescein at the center. So there is no touch of the cornea here. Then there is apical bearing, where the most of the contact lens is resting at the center of the cornea. So the darker area means there is no fluorescein. And then finally, there is the 3-point touch. So which is basically it's distributed all across. And a special mention here would be the rose-K, which is basically a custom-made RGP based on keratometry parameters. It has got multi-curve basically, which makes the visual quality better than the regular contact lenses. And it offers better comfort and a better fitting range. So sometimes even with like very steep corneas, which normal RGPs cannot be fitted, so that the rose-K can fit. However, these are again very expensive. Then the scleral group of lenses. So this is basically corneoscleral, miniscleral, and scleral. based on what the diameter is. So this is something, these family of lenses, they rest on the sclera and does not come with the cornea at all. So it's basically vaults over the cornea. So one, it converts the irregular surface to a smooth refracting surface, plus the intervening tear lens also contributes in correction of the refractive error part. So this is definitely more comfortable than the rigid gas RGP lenses with almost as good visual acuity. However, a long fitting time is required. So while fitting these lenses, you would want to look at the vaulting, the diameter, and the landing shape. So this, again, you want to, after fitting, check at the slit lamp, compare with the contact with the corneal thickness, or if you want to be more accurate, you can go for ASOCT measurements. So ideally something around 150 to 200 micron thickness at the center and around 50 to 100 micron clearance at the limbus is what is recommended. And nowadays, the initial concern was, since these are thicker material, whether the adequate oxygen will reach the cornea or not. But nowadays, the thinner materials are available. So definitely the oxygen supply is not a concern. Another thing to look at in these lenses is avoid compression of the limbal and conjunctival blood vessels. These would appear basically like pinching of the blood vessels. So you would see some blanching where the border of these scleral lenses are. And now you have all these very highly customizable lenses like the Boston Pros lens and the one fit lens from the Cooper Vision. So these you can basically customize at every level, the central, paracentral, limbal, and the peripheral, the landing zone. So everything is customizable. You can fit pretty much every sort of cornea, because now there is a concept of basically scleral toricity also, because the sclera is also not perfectly spherical. So you would want something in the contact lens edges which would fit according to the scleral toricity. So these are ideal for fitting in the very steep cones. So special cases, piggyback lenses, not very frequently used. It's basically where you would use a rigid gas permeable lens fitted over a soft contact lens. Hybrid lenses have some popularity. It's basically a mix of both the worlds. You have a central RGP with a soft peripheral skirt. So you would get a very good visual quality with the comfort of a soft lens. But again, since it's an RGP lens, so extremely thin, steep corneas may not be possible to be fitted. So again, complications of any contact lenses. So ill-fitting lenses can cause corneal or limbal damage, as we all know. So if there is a significant allergy, it can aggravate the papillae and may lead to even giant papillary conjunctivitis. And with poor hygiene and poor lens maintenance, there is always a risk of infectious keratitis. So practical lenses. So one thing to be remembered is, apart from the basic RGP lenses, the rest of specialty lenses are expensive. So these would, across the various parts of the country, the prices would be somewhere from between 25,000 for single lens to as much as up to, I've heard patients talk about paying as much as 80,000 for a single lens. So that itself becomes that the ones you mentioned the cost, that becomes a barrier for the uptake of these lenses. So it's very important to convince the patient for a trial first, because just by hearing the price, they tend to move away from the lenses without even getting to know the benefit of these lenses, because unless they wear it and get a feel of it, there is no way to explain it to them, the clarity of the vision that they will get with these lenses. So definitely that part you will have to convince them. Then talk about the economics. So most of the scleral family of lenses, if they're maintained well, they last you for maybe 3, sometimes 4 years. So at the end of 4 years, price works out close to maybe of the RGP lenses. And it would definitely be useful to have some teaching videos, brochures, some photographs in your contact lens, if you have a dedicated contact lens clinic, or even in your clinic also. So if you have these teaching videos and brochures, definitely it would help in patient conversion towards these lenses. So with this, I end my talk. Thank you very much.
Thank you. ask questions, relevant questions. Before that, these patients come at the age of 12, 13, 15 years, where you do.
Sorry, I couldn't hear you, Ashish.
Case, and you have the choice. Yeah. So
can you repeat once
more? So the patients come at the age of, so patients come at the age of. Sorry.
Your voice is.
Yeah. So these patients come at the age of 13 years or 14 years, and they have an advanced cone where you would like to give them scleral lenses. But the problem is they are so young, and if when I'm counseling them for scleral lenses, I think of the lifespan. Suppose they are living for the next 60 years. Are we actually prescribing them contact lenses for the next 60 years and asking them to change every 3 years? This is what goes through my mind while prescribing the lenses. So what I have developed over a period of time, I've realized once I have come into the private practice, my threshold for DALK has really decreased, and I tend to do DALK often, and then probably give them glasses or probably give them RGP lenses, which are relatively cheaper and easier. But this is a debatable topic. So I'd like to get the feedback from other panelists and Soham and others, please.
No, if it is like very steep cornea, young patients, yes. I mean, something like 80 or something, 80 Kmax, there is, I mean, really no point. Even if you have the parameters for cross-linking and contact lenses, DALK probably would be even my choice here.
Okay.
But I mean, this is like, it's a case by case basis, basically. It cannot be a blanket statement per se. But
two aspects to it. Like Ashish, as you said, one, the cost. What I'm talking is cost effectiveness. So that there's a difference between both of them, cost and cost effectiveness. Now you talk of like right now, let me announce openly. Earlier it used to like Swam said, it was 80,000 per eye. It was actually a little more than that a couple of years back, 1.25 lakhs per eye. Now it has come down to 40,000 per eye because we at Elmhurst have bought the copyright and are able to separate all of them. So that has reduced the cost by around 60-70%. One. Two. Now to look at two scenarios. One, the person has a transplant, young age, where the chance of rejection is very high. 2 versus 40,000 for 5 years, then 9,000 per year, then less than 1,000 per month. So let's put it that way. And the clarity of vision with a scleral lens is all what Swam said. It's a long time. 4 to 6 hours is not a long time for a patient whose vision is going to transform in a huge way after this sclerosis. What I suggest, make him put for 2 months, 2 hours. Thereafter, the patient will say, no, I want this. The kind of the 3D vision what we're talking about. I'm not talking about the visual chart and all. So there are 2 aspects to it. One, the visual quality what we give after scleral lenses. Let me tell you honestly, the most eclectic disorders like here also are correctable with scleral lenses. So in our practice here, the rate of DALK has reduced phenomenally after the use of scleral lenses in eastern part of India. 1. 2. At Elmhurst, let me openly say in this forum, we will give at no cost to the person if the person is not able to available. So cost should not be a factor for persons to avail the facility.
Thank you so much, sir.
All said and done. All said and done. What I'm trying to tell the other factors, the person who is spending I can assure you, 2 hours to 3 hours or maybe 4-6 hours is more than worth the money they spend for the lenses. So what we avoid is a transplant which can be done at any point of time.
Yeah.
Yes.
What we avoid is if we do it after 5 years later, the chance of rejection and him having a better in the long term is better, good. So there's a plus minus everything. So the patient doesn't have to come down every time. It is expensive, but cost effective.
Yes. Okay, sir. Thank you so much, sir, for generously announcing that we have now very low cost lenses. Because of the paucity of time, we'll move on to the next talk. Please, Dr. Rashmika.
Yeah, sure. So privileged to introduce my co-moderator and coordinator of the whole meeting today evening, Dr. Ashish Kedia. One thing I would like to add for Ashish is that he's a young and energetic cornea surgeon who has actually strengthened our cornea group in Bihar. So welcome, Ashish. So Dr. Ashish Kedia is working as cornea consultant at Lakshmi Netralaya Patna. He completed his cornea fellowship from Arvind Eye Hospital, Madurai, then did an advanced cornea fellowship with Professor Donald Tan and Professor Jodhpur Mehta from Singapore National Eye Center, Singapore. So Ashish, please carry on with your talk. Welcome.
Thank you so much, Dr. Rashmika. So I'm Dr. Ashish. I'll be talking about surgical management of keratoconus, and are my slides visible, Dr. Rashmika? Can you see my slides?
Yeah. We can see, Dr. Ashish.
So the scope of the talk I'll be talking about ICRS briefly, and then CXL Plus we have already spoken about. So mainly my talk would cover keratoplasty and a little bit about Bowman's membrane transplantation. ICRS, or the intracorneal ring segments, are a surgical alternative to decrease astigmatism and corneal abnormalities, thereby increasing the visual acuity to an acceptable level where we can avoid or delay corneal grafting for some time. Principle is very simple. If you add the tissues in the periphery, you will see a flattening, central flattening, and the concept is called arc shortening effect. And the indications are in cases of keratoconus where the vision doesn't improve adequately with spectacles, and some of the cases where patient is intolerant to contact lenses. So the mean keratometric changes which was seen after ICRS was varied between 2 to 9.6, and the effect of ICRS on the disease progression is questionable, and there are certain criteria only where we can do these ICRS. Best corrected visual acuity should be worse than 20/30. Corneal thickness should be at least 400 microns, and steep case should be less than 62 diopters, and there should be adequate stromal breadth around the rings, an absence of corneal opacity, and severe atopic disease it is also avoided in cases of large pupil. The complications are recurrent erosions, infections, and the ring exposure and extrusion. There is another technique which is called Keynes, which has become popular in the recent years. It's called corneal allogenic intrastromal ring segments combined with CXL, introduced by Dr. Susan Jacob. And basically here, instead of the introduce the corneal allogenic tissues into the cornea. And now we have already talked about this combined CXL and keratorefractive surgeries. Traditionally, if you see any LASIK or keratorefractive surgery is contraindicated in eyes with keratoconus, but here we are combining the same with the cross-linking to achieve better refractive and visual outcome. CXL plus is a term coined where any cross-linking procedure combined with at least 2 refractive procedures, then it is called CXL plus. And some of the protocols which we have already discussed here are the famous protocols are Athens and Triton protocol, and then you combine it with the toric phakic as mentioned by Dr. Smriti. The timing of combining PRK and CXL is again very debatable, whether we should do a silent. The most important concern radiation can penetrate deeper and then can lead to endothelial decompensation. And again, the other important considerations are ablation effect of PRK in porcelain corneas may differ, and PRK may actually increase the risk of progression if performed later because of the ablation in the anterior stroma. And MMC is sometimes used, most of the time it is used to reduce the haze. I'll be talking mostly on indications for keratoplasty in keratoconus, which is very advanced cone, post-hydrop scar, patients who are intolerant to contact lenses, and deep stromal scar. Again, it used to be a debate whether we should do PK or DALK, but now we have come to a conclusion where DALK is attempt DALK, and if only in very few conditions where we do PK in a case of keratoplasty. This is a trend state in a published study that lamellar keratoplasty increased from 5 to 58%, and PK dramatically decreased from 95 to 42% in the last decade. So DALK is nothing but a technique of corneal transplantation in which anterior layers of the cornea are removed and replaced while retaining the posterior layer along with the endothelium. There are two methods, basically, big bubble technique or the manual lamellar technique introduced by Melis. For successful big bubble DALK to obtain, I think consistency is one of the most important thing. You have to be consistent with your technique and the instruments which you're using, and there should be a right case selection. This is very important. You have to pre-plan everything. So topography is must, because you have to see the size of the cone and accordingly plan the size of the graft. You see the size of the cone both vertically and horizontally, and then plan also the corneal thickness. So you should see the depth of the trephination. You should decide the depth of the trephination, which should be around 30 to 60% of the anterior stromal dissection, and should at least leave residual thinness pachymetry of 150 to 200 microns before you inject bubble. Then if you don't size your graft well, you may end up with graft host junction ectasia, which is again very uncommon. But in large cones, you may tend to leave, if you're taking a smaller graft, probably you may end up with graft host junction ectasia after a couple of years. So the right tools and instruments are very important. I would always like to use TAN's marginal dissector and TAN's big bubble cannula. The rest of the things surgeons can have their own preference, but I will always suggest big bubble cannula and the dissector, which are very useful. There is a case of air bubble injection with a anastrofine. So I've done the dissection and detection already, and then I'm going inside with the TAN's marginal dissector, creating a track, going up to the mid periphery, and then coming out, and then I'll introduce the TAN's big bubble cannula. The important thing is I'll go beyond the track which was created by the dissector, reaching up to the center or just before the center, and inject air with a 5 cc syringe, and there you go. You have a big bubble, clear big bubble, and wait for the bubble to at least go beyond the rim of the graft, the host, and then do a paracentesis. Make sure that you don't bubble while doing a paracentesis. So in spite of all the planning, you may end up with circumstances where you don't want. So this is a anastrofine. I'm just checking it before going actually into the cornea. Probably in this case, I would have taken the full 5 cc full suction, and then I have landed up with something which nobody would like to desire. And there you see. So you have a perforation, aqueous coming out, and this is the case where you have to convert it to PK. I'll just skip it. This is another video of big bubble DALK. I'll skip it. So some of the common post-operative complications with DALK is you may end up with double AC, double anterior chamber. That's the immediate post-operative complication. And lately you can see high astigmatism, interface haze, infections, and graft dehiscence. These are some of the pictures where you'll see a sterile suture infiltrates. Then there's a rare case of epithelial cyst between the two, between the graft and the host. And then you have a double anterior chamber. Some of the advantages of DALK over PK is patient's own endothelium is preserved, so there's always a less risk of endothelial rejection. You have a stronger graft host junction. Yeah, it facilitates earlier removal of sutures, and there's a lesser requirement of topical steroids, which there's a less risk of glaucoma. It's an extraocular procedure that offers intraocular safety. And several studies are now reporting comparable visual outcomes after DALK and PK. This is one of the largest study corneal registry from Australia where it has shown that there's an increasing trend towards performing lamellar keratoplasty over the last 2 decades. And both the visual outcomes and graft survival was significantly better for PK when compared to DALK and DSEC. This is another meta-analysis where it has shown that visual outcomes for DALK were not equivalent to PK. The rate of graft failure was similar between DALK and PK. But an important point was fewer post-operative complications occurred in DALK group, indicating that compared with PK, DALK has lower efficacy but higher safety. These are some of the cases of DALK which I have done over a period of time. You'll see most of these cases are therapeutic grade, and you'll see the whitening at the edge. And the last photo, you'll see it's whitening at almost 360 degrees. This may not look very cosmetically good. I should have avoided therapeutic grade graft in this, but most of the time, this is a very in India at least, where you have many therapeutic grade tissues, you can use it for DALK. Another very important point: sizing of the donor. If the patient has a high myope along with the keratoconus, then you will tend to either take the same size as the same size of the graft and the donor, and sometimes you can actually decrease if it is too much of myopia. And also, while suturing, make sure that suture bite in the donor should be around 50 to 60% depth, and in the host around 90% for better apposition of DM with the donor. A little bit about Bowman's layer transplantation. Bowman's layer fragmentation is seen early in the course of keratoconus. So it was postulated that replacement of Bowman's layer can actually prevent further progression. There are a couple of studies. One of the studies has shown that long-term results of BLT has shown success rate of almost 84% at 5 years in terms of stable Kmax, stable best corrected visual acuity. And there were 3 cases of acute eye drops out of 22. Probably that has occurred because of the severe eye rubbing, and there was a history of atopy. It has not become very popular because of the technical difficulties in harvesting Bowman's layer, and also although placing the Bowman's layer in the eye is not very difficult, but I think harvesting is quite a challenging thing. Thank you so much. I would be happy to take any questions.
Very nice presentation. Beautiful big bubble.
I rushed through the presentation because of the paucity of the time.
Yeah, it was very fast. Anyways. So anything in corneal surgery will be incomplete without Samar Basak sir's inputs. So sir, please, we'll be privileged to listen from you. Sir is there, right?
I think he has just left. Or maybe he's
just left.
I think.
Okay, I would like to start with, yeah, I think sir was there. How often are we using, Dr. Ashish, intracorneal ring segments? Are we doing this now?
I don't think we are doing it very often. I think it used to be done. At least I'm not doing it. I'm sure there are.
Dr. Pran, any inputs with intracorneal ring segments?
Ma'am, the rate of intacs definitely has gone down, but it is still being used. Not in keratoconus patient, but in patients with post-LASIK ectasias. It is being done for because these are the patients who really want to be free of glasses or get their power reduced. So in post-LASIK ectasia, intacs with CTR is something which is, I think, is still being done. I have done it a couple of cases last year itself. So, but in pure keratoconus cases, no, I don't have much of an experience of intacs per se.
Dr. Rakhi, any inputs? Another prolific corneal surgeon in Bihar. Nilesh Mohan sir is also there. So please, your input.
Regarding IC intracorneal segments, I don't have much experience. I didn't use it.
I mean, regarding DALK or any other surgical inputs you have in cornea, what is your threshold for DALK? And
for keratoconus with the 65 diopter ectasia, we always prefer doing DALK rather scleral lenses, because here the patients are they cannot afford these scleral lenses of such a cost. So we prefer doing DALC, and as Dr. Ashish said, that we always use this B grade corneas in majority of the cases with the white rim. Ideally, we should avoid it, and we should use the good grade cornea for young kids and young adults. The prognosis of DALC in all the cases are really nice if we take the proper precaution. But one thing I would like to say here that we are using B grade eyes, right? Better to use these eyes after harvesting within 2 or 3 days, just to avoid any interface keratitis, because one, we are placing the patient at risk because we are using the B grade eyes. And secondly, if we do surgery after 3 or 4 days or 5 or 6 days after harvesting, then again the patients are at risk of developing some kind of interface keratitis. And this is really one complication which is nobody wants to see on day one. So better to in DALC, these things should be taken care of.
True, as ma'am said, that interface infection probably are the most difficult to treat. Post-PK infection, you can manage them still easily, but post-DSEC and post-DALC, the interface infections are difficult to deal with. And another thing that if we take tissues which are left in, say, in cortisol, say 5 or 7 days, the therapeutic grade tissues, they swell up way too much. And then your suturing and apposition of the graft-host junction, all that becomes difficult because your donor is very thick and your host as such is very thin. So at the graft-host junction, the suturing becomes difficult. So a fresh tissue, even a therapeutic grade tissue, I think that is what everybody across India is using for DALC.
So, for that, Pranita, I think
this is very important because once
very important to dehydrate the tissue. So I keep the as soon as I start the surgery, I keep the tissue. I take out the tissue from the Conusol and keep it on a Teflon block for some time, at least 20 minutes. It dehydrates, and then you attempt. Otherwise, again, it's a huge problem because you have a host.
You have a white thick cornea over a clear thin cornea.
Yeah.
Yeah, after doing everything, it's the worst when you puncture it while suturing.
Ashish, I just have one question, actually two. So you keep it on the Teflon block with, out of the media?
Yes.
For it to desiccate?
Yes.
Okay, yes. Because what I do is I keep it in the room temperature. So for about half an hour or more so that it cools down. And so I never heard of this. And my next question is, you mentioned the white rim, in the periphery, the white rim is because of the therapeutic grade. But is it because of that or because that the punch has been eccentric or the thick carcass of the donor that the white thing is there?
Thick carcass. We tend to grade all these tissues as therapeutic grade if they have a thick carcass and they have probably thick carcass. If it is localized, then probably you keep it at superiorly. But the one case which I was showing, it has 360 degree, and we get that tissue, and there's nothing I can do. So,
yeah.
Smriti, I'll just add to it what you said. What Ashish said is also correct. If you put on the Teflon block and put the media on it, it actually comes to room temperature quicker than any other ways. What point we are missing here is two. One, that is that necessary now with the advent of square lenses, what I said right now. There are very few cases where it is head drops and scar. Second question, have any of us noticed what is the fate of Gomez membrane transplant? There are many reports that over the 5 years they are successful. Why most of us do not do it? Is it reproducible? Correct. So it's the same thing. So there's a very few groups who report the good of these transplants. And a surgical procedure which is not reproducible. there's a problem either with the surgery or the yeah, there is what it amplifies. So I strongly feel either it is a underrated surgery that most of us are not doing, or it is an overrated surgery being published. So can we find out? Do look at it, how it is to be done. Is there a real indication and outcome? So DALC, we know it's a fantastic surgery, everything, but then the choices has gone on after sclerosis. Can we, as Eastern Joe, take up the challenge that either we say that women's milk transfusion is good or not useful at all? Well, this has been since, like you said, 5 years term, so which means 7 to 8 years it has been published, 10 years which has been done. But I, as a corneal surgeon, any of us do it. DMEC, on the other hand, started quite late after, and most of us have shifted to it. So let's put something for the world. Is it doable or is it not doable? And it's an open invitation for all of us to get in touch with each other and get into it.
Probably you're getting better results with DALC and scleral lenses. So that's why.
No. But then let's at least say that this is not a choice now.
Yeah, for sure. I mean, harvesting Bowman's layer is not easy. Probably that is why it has not become very popular.
Exactly, but then we tend to show that, okay, this is a choice, when this is actually not a choice.
Agree. Dr. Nidhi?
With that, Dr. Nidhi, Dr. Nidhi Gatta, please, your opinion or points you want to share?
Is she there?
Yeah. Sir, I wanted to ask Shrikant sir that for in advanced keratoconus, for how long will you be giving the scleral contact lens, and at what time would you stop giving the lens and shift to DALC? Because you have been promoting it, and I think it's really good. But at what point will you shift to DALC?
Okay. The moment I have a corneal scar because of hair drops, and let me tell you, Nidhi, even 50% of the hydrop patient with scar will be benefited with scleral lenses. I'm actually cutting my own legs, my own strengths, but then it is beneficial for the patients. Got my point? So actually, DALC is one of my favorite surgeries, but right now I'm against it when it benefits the larger population. So if there's scar which is not benefiting from scleral lenses, is the only thing where DALC is DALC or pending, whichever it is. There are some, let me again reiterate, there's some post-hydrop scar which also benefit from scleral lenses.
Is there a thickness cutoff that you take for DALC? Like personally, if a patient comes with a thickness say less than 200, that is when I personally don't give them an option for contact lenses. And
no, we need to change those concepts. We need to, like, that's what the best part of webinar is. Be open, be honest, and change the concept. We can change concept. The Eastern India can change the concept for the whole of India, or probably the globe. We can change.
So what about so if you are treating an acute hydrops and if you are doing compression sutures, then what about the scarring? That then eventually maybe we'll have to shift to keratoplasty after that.
Yes, that is what I said. Even let me tell you honestly, 30 to 40% of these scars, they're not central, are amenable for scleral lenses. 50% will still need of the hydroxyl with scar for a transplant. Where you and me, where we are born for.
Dr. Basak has
Thank you,
just
sir.
shown up.
Some of
Sir,
the
Yeah.
answer
No,
has
no,
been-
I was there. I was just
Please give your
took a
inputs.
short break.
Please give your input, sir.
So only thing I used to say to the keratoconus patient when they come with their parents, young usually, they counsel the patient that it is a disease of life. You have to live with the disease. And at the same time, I do separately counseling of the parents. Because last day, one boy, last week, and he is aspiring for medical MBBS. Already the one eye is advanced keratoconus. Other eye is like 6-12 with moderate keratoconus. So what will you do? So you will go for CXL in one, another is DELC. But the lifestyle and all these things will be changed forever. So the quality of life, and I asked him that what you will be. Well, I want to be a very good ophthalmic surgeon or ENT surgeon, like this kind of specialty. Then I counsel the parents separately that he can do medical. You go to the board and see what is the requirement criteria nowadays. Even I know nowadays with the Supreme Court order, with the one-eyed person can also read medical. That is there. So they can do, but then he has to choose a subject where the like skin, psychiatry, other kind of subject, general medicine. So this is one group because this patient by and large are intelligent patient. You see their intellect profile, half of the patient except that Varnal, you leave it alone. But otherwise they are IT people. They are doing engineering. Some of them you will see. They are doing. I know that I have treated so many doctors. They are in the first year, second year, or during their just admitted, then notice that this thing is happening. And I have operated few of them, like one eye DALC, one eye CX a long time back. But they cannot cope up with the specialty where they are trying to be. One of them very good ENT, but he has a limited practice, stable practice now. He cannot use the microscope because of limited vision in one eye, and whatever you will do, the DALC surgery never give very good vision. I was listening to Srikant that contact lens give the best vision. DALC, we have done so many DALCs. It doesn't give the best perfect. Even then, if you do DALC, you have to put another contact lens. Then the life will be smoother. But how long? As you rightly said, that till 60 years, 70 years. So whenever you are treating any young keratoconus patient, so you just be also tell them about their future. Try to tell their parents that I always tell them you must be a self-professional. You choose a subject, you must be a self-professional so that you need not to compete with others because they will be rejected by anybody nowadays. So that is the worst part of keratoconus. We used to, when people get whatever you are telling, all are fine. But at certain points of time, you realize that when you have started CXL at 2006, now I see those patients are not doing well. So we are not so much aggressive of treating keratoconus by CXL. Many of us, senior who have started very early, 2005-06, just came first time in the world and we had one. So when down the line, 15 years, you will see those cornea are totally different. Now you cannot describe those cornea, how they are flat, how they are thin, sometimes late melting occurring.
late melting occurring maybe after 10 years, 15 years. So these boys, we get girls, they grow over a period of time, then after 30, 40, then what they will do. So you have to counsel this patient and do not jump into the treatment. You try to think, try to educate the patient. Sometimes we need to do, because we know the first go you diagnose and you need to do CXL very fast because there is no time. And you may or may not save that, we are not sure. When the inflammatory background, other inflammation is going on, we do not know what will happen to those BKC-induced keratoconus or other allergic diseases keratoconus. So understanding is there. I think a lot of things we need to understand in future. DALC, it is a theoretically and practically also, it is a very nice surgery, nice to demonstrate, nice to create DALC. But at the end of the DALC procedure, what will happen? They will develop cataract after a few years of time. Half of the patient, because of steroid or because of whatever method you have used, it causes, unless if you enter the anterior chamber, you have disturbed the milieu of the eye. So at some point of time, you will see that one eye is fine, other eye keratoconus. DALC with cataract. Then what will you do? So binocular vision, everything will get disturbed. You cannot correct all the toricity, whatever the irregular toricity is there, you cannot correct. So again, go back to contact lens. So contact lens before keratoconus treatment, during treatment, after the treatment, after keratoplasty, keratoconus, they have to live with contact lens. But unfortunately, there are, I do not know, eastern part, especially, most of them are intolerant to contact lens. Few years, 1 to 3 years, and then suddenly I will not. So they go with one-eyed vision. So this is my saying overall with the over a period of say 25 years seeing keratoconus and treating with different modalities. I say that, and you have to also take care of the girls, because we know that hormonal imbalance during pregnancy, also a lot of changes. Again, we see suddenly 46, or why they will suddenly, there is a development of new keratoconus. We are just, it was a keratoconus suspect, so only observation. But suddenly the Kmax is more than 58. So you have to treat them. Now the question is, how will you treat her? So these are all practical things. So when you have a huge number of patients, you try to analyze their data, you are always, I always tell them that there is no cure for keratoconus. You have to live with the disease till last day of your life. So you accept it and take the best possible answer, whichever is suited for your eye at that particular time. We'll do that. We cannot do more, we cannot do less. So this is overall my view about keratoconus.
Thank you so much.
Basically, I feel non-interventional outlook is much better as long as we can do with lenses.
One minute. I agree with Dr. Prashad, and thanks for that. That they have to live with it, and transplant is something which does not be the best possible reason. Continue is the thing they live to. But I somehow differ with you, sir. One last sentence, that they should not, or those who have chosen ophthalmology or as a branch. Let me tell you, there are many branches in ophthalmology which does not need surgery, like community ophthalmology, UVA, corticovisual implantments. Sir, let me finish. I invite any ophthalmologist with a keratoconus who is not able to do regular surgery, because why I'm saying, well, that person will be so focused on certain things, will get other things who will do it just for a job. That person will do a job which will find answers which you and me will never be able to find.
No, that is correct. But everybody has a dream, like they will be like Srikant as a beautiful surgeon of Dalk. Tell me that who has this vision, I mean, not balanced vision, how can he grow that? That means what? The table practice. That means counseling part. That means that's what. I said that you come for the any branch of medicine, but you cannot satisfy yourself with your whatever people has dream in the early childhood and maybe early MBBS, that I will be like this, I will be like Samar Bashak sir. So I will be like beautiful
We will
retina
moderate
surgeon,
things to be there.
beautiful cataract surgeon. You say that they can come, they can do the, again, that is a kind of other thing, they can go, but that is not their extreme point of satisfaction. And in today's era, where there is competition, you know that we will be surplus ophthalmology by 2030 in India. So everybody has to sit idle. I mean, those who are in a institute in a good shape, but otherwise, bad time is coming for whole India. The doctor will be like engineers. They are just counting the how many cement bags are there. Some of the engineer, they are past engineer. The doctor will be like that. They will be just writing the prescription and copying the senior colleagues. If you calculate the doctor population ratio, we are at present surplus. So 2030, it will. That's why I told them not to go unless they have a family business. That is a different story. But individually, for a middle class family aspiring for a doctor with this background of keratoconus, I mean, there is a problem. There is a problem.
And
What is
why
what is the doctor population ratio in India now? What is the number of seats in MBBS? Because this is a point of discussion now. What is the number of seats in MBBS? Anybody can guess.
Sir, every district hospital is now converting into medical college.
No. How many seats this year has been declared by NMC?
1 lakh.
108,000 precisely. What is the doctor population ratio at this point of time? Considering 140 crore, what is the population ratio? What should be the ideal by WHO? WHO, what is the ideal doctor population ratio? And what is now? For 1 lakh population, how many doctors? Or 1 million doctors? There is a ratio. There are Ayurvedic and homeopathy, Unani, others are there. I'm not counting. I'm talking about only allopathy doctor. So ratio is 1:800. And it will come down to 1:582 by the year 2030. So that is the panic button. You must understand. Lot of people, you go to the thickly populated doctor population like Maharashtra. How many hours they are working? You just take an average of regular. I'm not talking about ophthalmology overall. So that is the problem will be India facing. And what is the ratio of ophthalmologists versus population? We need how many ophthalmologists? There is a definition for it. Right now, the ratio has been changed, and every year we are adding 1,800 ophthalmologists in the country. And how many are dying? Maybe 180. So after 10 years, Ashish, you will not be feeling difficulty, but those who are coming from middle class family, like us who used to come earlier, like many of us, they will find time to find a job in any place. Now people are hiring like that. All the corporate hospital are hiring like that. Come and do the night duty. So this, you just try to calculate this. I am thinking because of so many things. So that way, one side of the story, but disease will be there. We need to treat them. And there is a maldistribution in different parts of the country, urban, rural. Some city has plenty, some city doesn't have. But there will be a mismatch after 7 years. I have calculated the algorithm and arithmetic.
Okay, sir. Thank you so much for the. We'll have to really think about it.
Which country you are in?
Dr. Rishmika, you want to?
Yes, sir. What?
Yeah. We'll. I think it's
So
time
this-
that we've already
Yeah.
gone past our allotted time. Yeah.
So I hope everybody was benefited with this, and it was a beautiful discussion and presentations. Was a nice coordination, Dr. Ashish, and everyone who attended this and those who were part of it. Thank you so much.
On behalf of the IJOC Secretariat, my sincere thanks to Dr. Pranita, Dr. Shamar Basak, Dr. Ashish Kedia, BM Agarwal, Pranab sir, Rushmika, Dr. Nidhi, and everybody, and Dr. Srikanth, of course, who has been instrumental enough to make us motivated for long 2 hours. And Dr. Nidhi also. For long 2 hours, the time was scheduled for 1 hour. It has increased to 1.5 hours. I think in the next meeting, we should increase it to 2 hours at least, so that we can have this program very well done. Thank you so much. Thank you, everybody, to be with us.
Thank you.
Thank you.
Thank you.
So good night, everybody. Good night.
Good night.
Good night.
Good night.
Good night.